Good morning, everybody. Welcome back to our Global Neuroscience Institute Grand Round series. Now it is my pleasure to introduce our speaker, Dr. Scott Strenger. Dr. Scott Strenger received his medical degree from the University of Health Sciences, the Chicago Medical School in 1982. He completed neurosurgical residency at Mount Sinai Medical Center in New York, where he was chief resident. In 2002, Dr. Strenger received a Master of Medical Management degree from Tulane University School of Public Health and Tropical Medicine. Dr. Strenger is certified by the American Board of Neurological Surgery and was awarded fellowship status in the American College of Surgeons and the American Association of Neurological Surgeons. Dr. Strenger has held the positions of medical director and medical staff president at Shore Memorial Hospital, and has previously served as chairman of the Department of Surgery, as well as director of the Division of Neurosurgery at Atlantic Care. Dr. Strenger joined Global Neurosciences Institute in 2016 and is currently an assistant professor of neurosurgery at Drexel University College of Medicine. He's a member of the North American Spine Society, American Association of Neurological Surgeons, Congress of Neurological Surgeons, American College of Surgeons, and the American Association of Physician Leadership. He's also a longtime volunteer with the Boy Scouts of America, and Dr. Strenger currently serves as a council past president of Jersey Shore Council of Boy Scouts of America, and volunteers as senior medical staff for national and international Boy Scouts of America events. And Dr. Strenger will be speaking today about compression fractures. Dr. Strenger.
Thank you very much for that kind introduction, Peter. Let me get to my presentation. Thank you, everybody. So you'll notice that the title states pathologic compression fractures. When we use the term pathologic, we're normally implying neoplastic. But in this sense, we're talking about anybody who has really abnormal bone structure, and not just neoplastic disease, but there are a whole host of entities that weaken the bone structure, a most common being osteoporosis. And compression fractures are a very common issue with these patients. They cause significant pain, significant disability, and there are mechanisms for evaluating and treating these patients. There we go. So going through this, we're hopefully going to talk about the incidence of vertebral compression fractures, the many detrimental health consequences in addition to the pain that are associated with spinal deformity, risk factors for vertebral compression fractures, and the importance of early diagnosis. Also, the various vertebral compression fracture treatment options, including non-surgical management, pharmacologic therapy, minimally invasive vertebral augmentation, and even going so far as surgical stabilization. Vertebral compression fractures are extraordinarily common. Over 700,000 occur each year in the United States. Only about 1/3 of these come to clinical attention because everybody sort of brushes them, I got back pain. And underdiagnosis is a worldwide problem. 150,000 people a year are hospitalized annually during this due to the pain and the medical management. And once you hit 50, for women, the chances are 1 in 2 during your lifetime that you'll have one of these. And for men, it's not cheap odds. It's 1 in 4. Osteoporosis is a major public health threat for an estimated 44 million Americans. In other words, 55% of the people 50 years of age and older. 10 million individuals are already estimated to have osteoporosis, and 34 million are estimated to have low bone mass, placing them at increased risk for the disease. We are seeing younger and younger women showing up with osteoporosis because we have gone through a societal change in our habits. Our most common source of vitamin D is the sun. And nowadays, none of us go out with an SPF in the sun with anything less than a 6 million SPF. So we frequently lose the benefit of those rays. Also, we went through and are still to some extent through a period of time where our dietary preferences have shifted. Those in my age category can remember the days from elementary school when you got your milk carton and every teacher showed you the child with rickets over in the Far East, and you were encouraged to drink the milk products. Milk products have gone through a period of, shall we say, disaffection. And so less and less of them are being consumed. And what we're seeing is that younger women are approaching their adult years and senior years with a much lower calcium reserve than those of us from my generation. And obviously these compression fractures, the prevalence increases with age. This is basically a diagram showing for men and for women the incidence of vertebral body compression fractures as a function of age. And you can see that the women rise much, much greater than the men. However, everybody, as you get above age 65, your incidence starts to take off, and really above age 75, it becomes quite high. So what are the common risk factors? Well, we just talked about it. Age, low BMD, low bone mineral density. You don't have to be osteoporotic to have a vertebral compression fracture. You can be osteopenic. It changes your definition because if you get an insufficiency fracture while osteopenic, guess what? That qualifies as osteoporosis. Osteoporosis itself, and that's why the importance of DEXA scanning once patients hit the age of 50 is very important to maintain a concept of where their bone health is. Steroid use. Steroids are a big one. We use them for a lot of different medical issues, and chronic steroid use is very clearly associated with secondary osteoporosis. The youngest kyphoplasty I have ever done was in a young man aged 39. How does an age 39-year-old man get osteoporosis? He's on chronic steroid therapy for his malignant astrocytoma. The vertebral augmentation procedure becomes palliative for that individual with respect to his pain. Smoking is a factor for vertebral compression fractures. Other points are early menopause, malnutrition, unintentional weight loss, alcohol use, sedentary lifestyle. The best way to keep calcium in the bones is to exercise. And these can be insidious. They're not always apparent on an initial X-ray, and they can progressively collapse over the ensuing months. If you look at this MRI, it's very clear that this individual has a T12 compression deformity. But if you change the sequence of the MRI, you'll note that the T12 fracture is dark, indicating that it's a chronic finding. But the high signal in the bone edema, which is at T8, which if you look directly across at the other image, looks normal, is only seen with STIR MRI. And what you're usually looking for is high signal on STIR and low signal on T1 sequences. And these can get worse. This is a sequence from one of my older lectures. The MRI on the left is from January 2003. You can see the progression over the next month with developing retropulsion. And then finally in May of 2003, you can see the patient has severe cord compression with high signal in the cord. And now your hand is forced in terms of trying to salvage this situation. This is at T12, which is one of the high risk areas. And there are three common forms to these types of compression deformities. One is your standard run-of-the-mill anterior wedge compression deformity. You can see that the anterior column is markedly depressed compared to the posterior. When there's kyphosis associated with this, what happens is that the posterior superior margin takes on the appearance of a retropulsed portion of the bone as opposed to just being the kyphosis. I've seen that misread by radiologists on many, many occasions. In the middle, you have a biconcave fracture where both superior and inferior end plates have been compressed. Posterior elements remain intact in these. And the crush fracture is basically, this is the empty Coca-Cola can that you decided to crush against the sidewalk, and you just flatten the bone. The wedge fractures are the most common. These can occur commonly. Minimal trauma, day-to-day activities. It's listing bending forward, lifting objects, climbing stairs. I've had patients wake up with them from bed. I've had patients literally look at me and say, I don't know what I did. Essentially, it's the routine activities of daily living, and the forces have exceeded the structural integrity of the bone involved. So the most common locations are the mid-thoracic region in T7 and T8, and the thoracolumbar junction, T12 through L1. The reason being is that this is where the greatest stress is applied. You can see that these locations are at the apex of the various curvatures in the thoracolumbar spine. Thoracic kyphosis is most pronounced in the mid-thoracic region. And at the thoracolumbar junction, you've got the rigid thoracic spine, which is fixated by the rib cage, and you have the more freely mobile lumbar segments. Certainly, you can have compression deformities in the lower lumbar spine as well. I've treated these fractures from T4 down through and including sacrum. And yes, once you've had one, you can get others. After your first vertebral fracture, the risk of subsequent vertebral compression fractures is increased. And if you look at this, you can see that it's 5-fold after your first vertebral compression fracture, 12-fold after 2 vertebral compression fractures. And if you have low bone mass below the 33rd percentile, you have a 75-fold increased risk of subsequent vertebral compression fractures. So this is a real problem. Not only do you have to deal with the impact of the fracture, but you have to deal with the underlying process that's putting the patient at risk for these, meaning you have to deal with what is decreasing the bone density, be it osteoporosis, neoplastic disease, what have you. So what's the impact? It's a compression fracture, big deal. Well, chronic debilitating pain. As kyphosis progresses, you'll see decreased lung function in both vital capacity and FEV1. You get impaired physical function, impaired gait or poorer balance, which leads to further falls. Patients develop early satiety and gastric distress because they just don't have the space anymore. The thoracic kyphosis decreases the volume of the chest cavity and also decreases how well patients can swallow and consume their food. Their activities of daily living become diminished. They have increased dependence on family members and friends for mobilization and getting places and doing things. And this leads, no surprise, to anxiety and or depression. Obviously, there's the risk of future fractures with patients that are now poorly mobile. And all of this leads to an increased mortality rate. If you look at the pulmonary function, FEV1, it's significantly reduced in patients with osteoporotic compression fractures as compared to those patients who just have low back pain without osteoporosis present. The vertebral compression fractures produce these declines are predictable, and therefore treatment becomes more, I'm not going to say the word mandated, but they wind up being in the patient's best interest. There's decreased health-related quality of life. And again, this is a function of how many fractures the patients have. And if you look, you can see their physical function is significantly better with no fractures. And when you compare it to greater than 3 fractures, you can see the marked decrease in health-related quality of life. So this basically becomes a spiral, which is a downhill spiral. Back pain, deformity, decreased lung capacity, function becomes impaired, and it just continues to spiral inwards and impacts the patient's life and life expectancy significantly. So what do we do about this? Well, the National Osteoporosis Foundation has a clinician's guide to the prevention and treatment of osteoporosis. This is available online. It was originally released in February of 2008. And one of the most useful things is the FRAX tool, which is a World Health Organization fracture risk assessment tool. They've published cost-effective osteoporosis treatment thresholds. And also, there are articles on the implications of absolute fracture risk and guidelines. If you want to go actually see the FRAX utility, yes, you go to the National Osteoporosis Foundation website, navigate to professionals and bone source. And in the middle of the page, there's a drop-down that's choose FRAX tool. And that takes you to a link for the FRAX tool. And there's a choose, and you can drop down your menu for men and women. And you can see how this can be affected by how the patients identify themselves. And this is sort of a, yes, there's an app for that. And it's very easy, takes you right through the steps, and you can even keep track of your patients on it and save their scores. It gives you the 10-year probability of fracture for major osteoporotic fractures, meaning vertebral fractures, as well as the 10-year probability for a hip fracture based on their bone mineral density and their BMIs. So bone mineral density testing is indicated for women greater than 65 and men greater than 70, regardless of their risk factors. When you have younger postmenopausal women and men who are 50 to 70 and their risk factor profile, you're thinking about them for pharmacologic therapy, yes, bone mineral density testing is essential because you got to keep track of it. Fracture in an adult greater than 50 years. You need to check what their bone health is. Adults with conditions or medications associated with low bone mass or bone loss, read chronic steroid therapy. Also, obviously, patients that are on chemotherapy, you want to repeat testing anyone treated for osteoporosis to monitor treatment effects. And you also for restratification of postmenopausal women that are discontinuing hormone therapy. Steroids, 2.6-fold increased risk of vertebral fracture when compared to age and gender match controls for patients that are not on chronic oral glucocorticoids. Metastatic cancer and multiple myeloma, 75 to 100,000 cancer-induced vertebral compression fractures occur annually in the US. Mostly, this is stage 4 breast and stage 4 lung cancer, any stage of multiple myeloma, and we'll talk about that in a minute, and also stage 3 and stage 4 prostate cancer. And you can see the distribution with prostate cancer at 32%, lung at 20%, breast at 6%, myeloma at 22%, and everybody else at 20%. (33% of patients with bone metastases can experience vertebral compression fractures. And interestingly, up to 50% of patients with metastatic breast cancer will develop a vertebral compression fracture. Androgen deprivation therapy can control metastatic prostate cancer. For long periods of time, but one of the important side effects of this is secondary osteoporosis after 18 to 39 months. Multiple myeloma. Multiple myeloma classically is characterized as multiple lytic lesions, although patients can present just as diffuse osteoporosis. In 2015, an estimated 28,850 new cases were diagnosed in the US. When I gave this lecture years ago and was using 2009 data, those numbers were 19,000 and change. And if you look below, you can see that the American Cancer Society is expecting that about 34,900 new cases will be diagnosed in 2021. 55 to 70% of multiple myeloma patients already have vertebral compression fractures at the time of diagnosis. And in fact, about a third of multiple myeloma patients, the vertebral compression fracture is their presenting finding. Half of myeloma patients have at least one osteolytic lesion, will develop a pathologic fracture within 9 months. And you can see the mortality rate from myeloma that's expected in 2021, about 12,400. So first off, you need a solid neurologic evaluation on these patients. Usually they'll just show up with an X-ray. Oh, they've got a compression fracture. So you need additional imaging. CT scan is very good for looking at the anatomy of the fracture. But MRI will actually give you the aging. CT will tell you nothing about the age of a compression deformity unless you have a very recent CT from a period of time preceding the one that you're demonstrating the fracture that shows it's not there. MRI is best for aging the fracture. And again, you're looking for that high signal on stir sequence and that low matching low signal on T1 indicative of bone edema. Laboratory studies should be obtained, CBC, biochemistry profile, vitamin D level, in men, a serum testosterone. If you're concerned about malignancy, yes, serum and urine protein electrophoresis, SED rate, C-reactive protein. The vitamin D level is an interesting one because a lot of these patients, especially when they're osteoporotic, are vitamin D deficient. And that can happen at a startlingly young age. My daughter was diagnosed with vitamin D deficiency in her early 20s when she switched from her pediatrician to her adult primary care physician. So, treatment goals. Number one, making sure their calcium and vitamin D intake is adequate. Getting rid of the adverse influences, tobacco, alcohol, medications. Weight-bearing exercise. This puts a lot of stress on the spine. One of the best things that you can do for a patient who's osteoporotic and you want them to actively exercise is see if they can find a local community center with a pool, because most of these patients are seniors and most of these centers have senior aquatics. So the patients are getting their exercise, their cardiovascular improvement in a low stress environment for their spine. Obviously, you need to undergo fracture risk assessment and fall risk for these patients. You need to stabilize or increase bone mass and ensure whatever interventions you are providing are tolerable with long-term safety. And is there a role for surgical intervention? For mild to moderate pain, oral analgesics are sufficient for initial management. Tylenol, ibuprofen, naproxen are frequently sufficient. For more significant pain, short-term opioids, especially with the influence nowadays on trying to stay away from these. And interestingly, calcitonin still has a role in treatment of these patients, which can provide short-term pain relief over a 2 to 4 week course until you can get them onto a more effective osteoporosis treatment regimen. For severe pain, these typically require opioids at the outset. And if the pain is incapacitating, hospital admission and parenteral analgesics may actually be necessary. I think I'm having problems with my screen share.
No, we can see you.
Okay, thank you. Sorry, because I just got a notification that says, oh, they can see your now. So bracing, let's talk about this for a second. Very common response for a compression fraction, regardless of what the etiology is to throw the patient in a brace. If a brace is really used to relieve pain, it should be used in the acute or subacute phases for the treatment of pain control. But don't use it forever because you atrophy the core musculature. And despite the fact of how we've been trained, there is no randomized evidence-based study to suggest that using a brace is clinically superior to not. When I was in residency, I was trained, you threw the patient in a brace. I have since changed my practice, and I use this as a comfort measure. If a patient's uncomfortable enough that they want a brace, I give them a brace, but I don't give it to them for a long-term period of time. It weakens their spinal musculature. So I'm a surgeon, surgical intervention. One of the first interventions for these types of fractures was a procedure called vertebroplasty. It's a percutaneous bone cement injection. It began in France in 1986 and in the United States in 1995. And it provides actually quite good relief in the majority of patients. There's a low rate of complications. And it's a very straightforward procedure where you stick a large needle into the broken vertebral body and you inject polymethyl methacrylate, you inject an acrylic cement, you glue the fracture. What you're doing is you're stabilizing the fracture lines in the bone itself, and that cuts down on the patient's pain. These patients will frequently tell you that if I lay completely still, it will tend to leave me alone. And the moment that I move, I see stars. And what the cement does is it helps to stabilize the fracture lines within the bone. Now, vertebroplasty requires passive percolation of the cement through the bone from the injection site. Interestingly, the first vertebroplasty in France was done on an upper cervical spine fracture, which really nobody is doing now because it's only approved from T1 down through L5 and sacrum. About 60 to 100% of patients reported decreased pain within 72 hours. That was sustainable. They had improved functional levels, and they decreased their use of analgesic medication. Kyphoplasty is a similar procedure, but it's a little bit more advanced. One of the biggest issues with vertebroplasty was the potential for leakage of the cement through the fracture lines and through the venous drainage of the bone into the spinal canal. Kyphoplasty is a procedure where you basically are using a balloon tamp to create a cavity within the bone, which compresses the cancellous bone to the outer margins. And sometimes you can actually restore vertebral body height. It's minimally invasive, but it requires small incisions. It's about an hour in terms of the actual procedure room time. The procedure itself actually only takes 25 to 30 minutes, but once the patient is anesthetized and now you position the patient, sometimes you take longer positioning your C-arms to get a good view of your fracture because these patients are frequently kyphotic and scoliotic than it does to actually do the procedure. It can be done under general anesthesia, which I tend to prefer, but on medically frail patients, local anesthesia supplemented by conscious sedation can be performed. On an elective outpatient procedure, this is not eligible for an overnight hospital stay. This is a same-day procedure. Patients have minimal bed rest after the coming out of the procedure room, and then they're mobilized and discharged to home. For the inpatients, they can be discharged that afternoon if they're done early enough. It depends on how long they've been inactive and whether or not they need a rehabilitative stay to recover their level of function. So kyphoplasty is done a little bit differently than vertebroplasty. Here you can see the wedge fracture on the left, the insertion of the cannula and the balloon tamp on the middle. And then you deflate the balloon tamp, withdraw it, and you fill the created cavity with bone cement. This creates an internal cast and stabilizes the fracture. And this is what a balloon kyphoplasty procedure looks like. You can see the compression deformity on the left-hand side in both AP and lateral projection. And postoperatively, you can see on the right-hand side in the lateral projection, there's been improvement in the bone height, and you can see the distribution of the cement within the vertebral body, structurally reinforcing it. Balloon kyphoplasty has improvement in activities of daily living and for standing, lifting, and bending. You can see the baselines at 1 month post-procedure and at 24 months post-procedure. And these are statistically significant. Quality of life, similar improvements. Social function, bodily pain, and their physical role. You can see where they are at baseline, and following the procedure, they were highly impaired beforehand, significant, immediate, and sustained improvement with pain reduction. In at least 10%, there was at least a 10% height restoration in 82% of patients. The patients are highly satisfied, and no serious or device-related complications during a 2-year follow-up. This is one of my case studies. It's a 66-year-old Caucasian female. She had a total esophagectomy with pull-through for carcinoma. 4 months post-op, she got back pain and became worse over the next 4 months. She had a pathologic fracture at L4 with a PET scan showing metastatic lymphadenopathy in the right paratracheal region. She was treated with medication, radiation therapy. Her pain worsened. They got a follow-up MRI on her after first diagnosing the fracture, and it showed progression of her fracture. An L4 kyphoplasty was performed, and she was discharged markedly improved on postoperative day number 2. The patient was from a remote area, and my follow-up on her was a telephone contact with her and her family, which indicated at 1 month that she was pain-free from her fracture and undergoing chemotherapy. I did not have any further contact with the patient or her family until records finally came that indicated that she was expired ultimately from her systemic disease. But she had been pain-free from her fracture, and her husband was extremely grateful for the procedure being performed. So what's the next advance? Mechanical kyphoplasty. You saw me using balloons on this last one. And this is controlled anatomic restoration with a device that, if you look at it, look at image number 7, that looks like the jack that's in the back of your car. And in a miniature version, that's very close to what this is. It's a cannulated access. It's done bilaterally. A reamer is placed in. There's a template. Preoperative imaging studies are measured to determine the size of the implant that you use. The implant is inserted closed, as you can see, and is then progressively expanded under fluoroscopy. And this device is very good for restoring height in a vertebral fracture. And then after the devices are fully expanded, a cement fill is done with the devices in place. And this is what it looks like. And you can see the device in there being expanded. I think I have a picture of, yes, there we are. And there's the cement being injected. It's an anterior injection point. The implant is actually connected to the injection tube. And the goal of the injection is to obtain a C shape to reinforce and stabilize the anterior portion of the vertebra. Again, the results are extremely good. And in fact, a recent trial, and to some extent industry supported, demonstrated greater pain score improvements than the balloon procedure at 6 months and at 12 months. Oh, I didn't delete the name. I'm sorry. Not supposed to do that. But those, again, it's an outpatient procedure. It does not require an overnight hospital stay. You know, it's 2 Band-Aids on the back over skin glue. Now, sometimes compression fractures are not so straightforward and simple. You have to evaluate the anatomy of each one. And sometimes you've got to do what you've got to do. For fractures that are unstable or that have significant retropulsion with neural compression, where you need to deal with that. In patients with exceedingly osteoporotic bone, how do you deal with this? Well, we have instrumentation systems, and you can see the compression fracture on the left, particular screw fixation going in. And remember, we're putting these screws into soft bone. But then these particular screws are fenestrated and allow us to inject bone cement like a kyphoplasty directly through the screws to help stabilize the screw within the osteoporotic bone. And doing that, you can actually distract against the screws and look at the improvement in height of the vertebral fracture with the bone screws cemented at all 4 levels. So sometimes it's not just a vertebroplasty or a kyphoplasty. Sometimes you have to take the plunge. So in summary, osteoporosis affects a significant proportion of the global population, particularly postmenopausal women. They are a common result of poor bone quality due to osteoporosis, steroids, and cancer. Yet most really don't come to our attention because, oh, it's back pain. There are many detrimental health consequences independent of the pain that are associated with resulting spiral deformity. And we talked about this: physical capabilities, social interaction, the psychological depression that occurs with this. The compression fractures significantly increase mortality rate, specifically in terms of pulmonary morbidity, because of decreased vital capacity and FEV1. So correcting the pain from the compression fracture, and if you can improve the kyphosis, all the better. So the key to this is to diagnose them as early as possible to prevent further progression of the deformity and the associated consequences. The earlier you find these fractures, the easier they are to deal with, and the better results from your interventions. Non-surgical management can treat the pain, but it doesn't treat the resulting deformity from the vertebral compression fracture. And if the patient declines any form of intervention, you need to keep careful watch with serial x-rays to watch for further compression deformity and kyphosis. Patients with recent vertebral compression fractures with axial pain, tenderness that lessens when they're lying in bed and doing nothing, and the abnormal MRI can potentially benefit from minimally invasive surgical intervention, such as vertebroplasty or balloon or mechanical kyphoplasty. But again, these have to be active fractures with abnormal signal on STIR and T1 sequences. Chronic compression fractures, this won't work. And either technique for kyphoplasty can not only provide fracture stabilization, but potentially can correct the spinal deformity. A recent addition to the balloon kyphoplasty instrumentation is what are called directional cannulas, where instead of just generally expanding the balloon within the vertebral body, you can insert your balloon over a directional cannula, which will direct your expansion superiorly, inferiorly, or whichever direction you need to address. And that's been a bit of a game changer for the balloon kyphoplasty industry, and is their answer to the mechanical kyphoplasty devices that are in place. So we're running out of time. I wanted to leave enough time for questions. Thank you very much for your patience and listening to me. And if there are any questions, I'm more than happy to take them.
Absolutely, Dr. Strenger, excellent talk. I don't think it can be any clearer about it, but we do have some questions. What are your recommendations for exercises after somebody who already had compression fracture? And in 2 case scenarios, one when that was treated surgically and when if it wasn't treated surgically.
I am a big fan of aquatic exercise. These patients are already fragile with respect to their bone, and to try and put them in an aerobics course where they got to go up and down a step, it's putting them at risk. The aquatic aerobics gives them their cardiovascular benefit, and they're doing it in a relatively low stress, weightless environment. And that's the key: low stress on the spine. But keeping the exercise, that's the key to keeping the calcium in the bones. If you don't use it, you lose it.
Now, for an acute vertebral compression fracture without significant repulsion, if pain is controlled adequately, can these patients routinely follow up in the office, or is there any urgency to be evaluated by you quickly?
It's always nice to be evaluated. I never mind them. But again, kyphoplasty, vertebroplasty, mechanical kyphoplasty, these are pain procedures. You're primarily addressing the pain of the fracture as opposed to the actual structure. If the patient's feeling good and doesn't feel that their pain is bad enough to warrant a surgical intervention, there's nothing wrong with following a fracture. But again, you have to do that closely, because at the first sign that the fracture is failing further, and now you're starting to develop further decrease in loss of height or potentially even kyphosis, you need to really talk to your patient about the potential benefits for intervention.
Okay. Would you recommend that all women over 50 with back pain be evaluated?
Certainly anybody over the age of 50 needs a bone, needs a DEXA scan, number one, okay? And at the very least, if they're complaining of back pain, yes, they should get at least an X-ray to take a look and see what's going on. And if there's a compression deformity present, then yes, that leads to the DEXA scan, that leads to potentially advanced imaging. And it really depends. Not all back pain is just plain back pain, especially in this age category. I talked about the youngest patient that I have done a kyphoplasty on, the 39-year-old with the grade 3 astrocytoma with steroid-induced osteoporosis. The oldest patient I've personally ever done a kyphoplasty on is 99 years old. She did great, and I discharged her 1 month post-operative. And I've talked to a nurse anesthetist who, prior to me operating on her family member, told me, oh, I just did anesthesia on a 101-year-old for this procedure 3 weeks ago. So age is something to be respected, but is not something to be feared.
Absolutely. Now, again, more about the exercises. What are the exercise restrictions for somebody who is at a high risk of fractures, compression fractures included?
Stay away from lifting exercises, anything that's going to put an axial load on the spine. Find another way to get your cardiovascular benefit. Swimming, the aquatic aerobics. I'm a little hesitant about the steppers, because even though you're not actually going up a stairs, you're still shifting your body weight. And yes, you're translating those forces to your spine. So, what you want is low impact and low stress on the spine.
And for somebody who is on a chronic steroid therapy, how frequently would you recommend checking them for osteoporosis?
That's a really good question. Okay. And a lot of this is dependent upon your healthcare insurance. Medicare will allow you to have a repeat DEXA scan every 2 years, not every 1 year, 364 days. It's every 2 years. And you should absolutely follow that to the best that you can.
Okay.
Oh.
Now, somebody who already had a compression fracture, does treatment for osteoporosis improve their healing and reduce the risk of the further fractures?
Treatment of the underlying osteoporosis remember, the fracture's already been treated. It's been cemented. Okay. And we haven't talked about adjacent segment fractures, which can occur. But again, that's the goal of treating the underlying process, the osteoporosis. Yes, that will reduce your risk of further fractures, especially if you can demonstrate that your bone mineral density has improved on your sequential studies, because you're less likely to get a fracture then.
Mm-hmm. Now, what would be your estimate? How many patients with compression fractures get surgical treatment?
I have probably I started doing these procedures back in 2008. And over that course of time, I have somewhere probably closing in on anywhere from 450 to 500 patients that I've treated, with well over 600 to 700 fracture levels between them. Many patients have multiple compression fractures. I had a high school guidance counselor who was on chronic steroid therapy for inflammatory bowel disease. And I had done 6 of these augmentation procedures, kyphoplasty procedures on him for various compression fractures. He came into my office one day and the opening words out of his mouth was, "I did something stupid playing with my granddaughter, just find out which one it is and fix it." So, these fractures can be avoided with good attention to bone health.
The compression fracture that presents only with a mild or moderate pain, is that an indication for surgical treatment?
That depends on the impact on the quality of life of activities of daily living. That's a judgment call from the patient. If their pain is only mild to moderate and they're being controlled with non-steroidal anti-inflammatory agents, it really depends on what activities they're finding impacted from the fracture, from their need to use medication, and whether they find that an acceptable quality of life.
Okay.
If they look at me and say, "Doc, I'm fine, but all I do is I sit in my house and I'm like a roll of salami fresh out of the supermarket. I can't do anything. If I try to do anything, I get my pain." Then yes, then there's a role for surgical intervention to improve their functional status.
Now, sounds like vertebroplasty or kyphoplasty is fairly effective in treatment of compression fractures. So why isn't it used even in mild cases?
Pardon me?
So it sounds like a vertebroplasty is fairly effective in the treatment of compression fractures.
Now I understand. So why isn't it used in mild cases? Because it's a surgical procedure and it has risks. I have a surgical risk-benefit discussion with all of my patients for these procedures. Risks range from general anesthesia, where there's never a 0% risk. The blood loss is minimal. It's maybe a tablespoon at most. Infection rate is very tiny. It's less than 2%, just as with any surgical procedure. We give antibiotics. We're going through a sterile environment, but anytime you go through the skin, there is always a risk of infection, even as minimally invasive as this. And what you're introducing is a foreign body into the patient, which will be there for all of their life. And that can make an infection extremely difficult to treat. And obviously there's the neural risk from the procedure. Yes, the cement can leak out into the spinal canal and can cause nerve compression. You can wind up doing an emergency decompressive procedure for compression within the spinal canal from extravasated cement. The cement can get into the venous system and can go to the lungs, and there's reported pulmonary emboli from embolized cement. So you have to be very careful as you're injecting this, watching the venous drainage from the bone, and that's one of the indications for stopping the procedure immediately. So this is not a without risk procedure. And like any surgical procedure, it's up to the patient to judge whether their quality of life is worth going through something like this.
Now, what is the most, how many levels can you treat at one time? What is the most amount of levels that can be treated at one time?
That is another very good question. That depends on who you're asking. That depends on whether you're asking me or whether you're asking the institution. Mm-hmm. For me, it really doesn't matter how many levels. The most I've ever done at one sitting is 4. That's not great, because the more you're injecting cement, the more at risk you're placing the patient for some type of an embolic event. Usually I'll do 2 if there's 2 fractures, and I can get them into the same field. Okay. The institution, however, would absolutely not like me to do more than 2, because the DRG, which is the diagnosis related group, which is the basis for how these institutions get paid. And please understand that 85% of these patients are greater than age 65. There's a DRG for a single level kyphoplasty, single level vertebral fracture, where the institution does very well financially. For a 2-level procedure, it's break even. If I do anything more than 2 levels, the institution is losing money, and not an insignificant amount. So the institution would not like me to do any more than 2.
Okay. All right. Now, I'm going to a little bit paraphrase this question, but there is a rare systemic issues when pressurizing femoral canal during the certain ortho surgeries. Has this been reported, or have you seen this with the procedures we described?
Actually, no, I haven't, because the pressure I'm applying, when you think about it, on a balloon kyphoplasty, the only pressure that's being applied is within the balloon, inflating it with contrast. The only time the patient gets actually even exposed to that contrast is if a balloon happens to rupture, which is extremely rare. As far as the injection of the cement, that's done under hand control, under direct visualization, under fluoroscopy, and it's done filling a cavity from front to back. Same thing with the mechanical kyphoplasties. All of these are hand controlled. There are some remote, okay? But again, what you're watching is the spread of the cement, and if it starts getting into the lumbar venous drainage and escaping from the lumbar vertebral body, that's one of the indications that we use to stop.
Okay. Dr. Strenger, thank you very much. It was a great talk, and obviously there was a great interest in your talk. Thank you very much, and have a good weekend.
Thank you all.